Welcome to Brain Tumor Talk, a podcast brought to you by the Ivy Brain Tumor Center at Barrow Neurological Institute. This show unites leading experts, inspiring survivors, and compassionate caregivers in conversations about the latest in research and treatment. Together, we share stories filled with challenges and hope. I am your host, Michelle Palacino, a member of the Ivy Center team. My deep understanding of brain cancer comes from both my professional insights and personal experience as the daughter of a brain cancer patient. Brain Tumor Talk is your invitation to connect, learn, and find support in this community. The information shared on this podcast is for educational and informational purposes only. Nothing stated on this podcast should be considered medical advice. Welcome to Brain Tumor Talk. On today's episode, we're here with Dr. William Kennedy, a radiation oncologist at the Ivy Brain Tumor Center at Barrow Neurological Institute. On today's episode, we're diving into everything radiation oncology related. Dr. Kennedy, thank you so much for being here.
Thanks for having me.
Okay, so can we start off this episode with you telling us about your role at the Ivy Brain Tumor Center and at Barrow?
So, radiation oncologist, that's my main role. And so basically what that entails is I kind of work on a team with the neurosurgeons, the neuro-oncologists, and everyone else on the team. And my specialty is in figuring out, A, for someone with a diagnosis of a brain tumor, would they benefit from radiation therapy? And then if so, I'm the one with my team to make the radiation plan and deliver it and then follow them afterwards as well.
So what is radiation therapy, if you were to just give a high-level overview of it?
Yep, so it's using some form of energy, whether usually it's X-rays or basically light waves. Sometimes we use things like something called proton therapy, that's charged particles. Anyway, some sort of beams basically that are delivered with different machines from outside the patient and kind of focusing in on either a tumor that a surgeon can't reach or an area at risk after a surgery to try and basically kill tumor cells.
So these beams basically hit cancer cells, and they're designed to damage the DNA in cancer cells?
Yep.
So when you mentioned planning, what does the planning process typically look like for a brain tumor patient?
Right. So there's a bunch of different steps. Really, before we most of the technical side of it actually happens well before a patient comes for their first day of radiation. So usually about a week or so before we start radiation therapy, they come into my office and do something called a simulation. So that's just fancy words for like a dry run, a planning session. So they come into my department, they're lying on a table. We make this plastic mask for brain tumor patients at least. There's all sorts of different parts of the body that radiation's used for, but in the setting of brain tumor patients, we make this plastic mask that keeps their head and neck in the same spot during the treatment. We'll usually repeat an MRI, a brain MRI, that same day, and then they go home. And then basically what me and my team are doing in the background is, basically on that MRI outlining the tumor or just basically the target, the area we want to kind of focus on, all the really important normal nearby parts of the brain, and then figure out through a rigorous safety and quality assurance process in the background how to basically treat the target and treat the tumor without causing collateral damage to all the important normal nearby stuff. So it's a kind of a big push and pull process in the background with me and my team, and figuring all the different angles and energies and all this nerdy stuff in the background. And then usually about a week later, after all those checks are met, then we basically have the patient come in and they start their first treatment. So
when they start the treatment, how long is that process? Does it fluctuate based off of each patient, or is there generally like a standard of care duration that they all go through?
Yeah, so there's obviously different standards based on decades of trial and error. But for someone with a type of a brain tumor called a glioma, so that encompasses glioblastoma, oligodendrogliomas, low-grade astrocytomas, basically some of the more common types of primary brain tumors. Usually we're giving a little bit of a radiation dose every day for several weeks. It's usually about 6 weeks, about 30 treatments. And that's pretty standard throughout the country. And basically we're giving just a little bit of a dose every day spread out over that several weeks. Because if you try and deliver too much of a dose in a given day or in a shorter course, sometimes it's a little too tough on patients. Now, every patient's a little bit different. Just the number of treatments is only one piece of the puzzle. Even in an individual, like different individuals with the same diagnosis, the plans like behind the scenes look very different. But for different types of brain tumors, different diagnoses, sometimes we can do treatments as short as 1 day. But then again, about as long as 6 or 7 weeks. So anywhere in between.
So for the glioma patients, they're coming in for 6 weeks. It's every day, 5 days a week.
Right.
How long are the sessions typically?
Each session's usually about 10 to 15 minutes. So when they come in, they come back into the department. We get them back on a table. It's open. It's not closed like an MRI. We'll put that mask, that custom-made mask back on, take a couple pictures, basically make sure they're lined up just right. There's a lot of really intricate, sophisticated imaging and guidance and all that in the room and on the machine itself. And then basically the machine, it's called a linear accelerator, rotates around from a bunch of different angles. It's almost like getting a CAT scan every day. So that 10 to 15 minutes, most of that's just getting the patient set up just right, because we want to be as precise as possible. And then the actual treatment's delivered just over a course of a few minutes, and then they go about their day.
Yeah. So the longest part of this for most patients, I feel like, is the commute to the center.
Of course.
And so it is a huge time commitment. Would you say that most patients after these treatments are able to drive themselves, or would you say that no, absolutely, I would not recommend anybody drives themselves?
Yeah. So for most there's a couple nuances there. So when we're talking purely in the brain tumor space, because I also care for patients with head and neck cancer, skin cancers, and all sorts of other things. But in the setting of a standard radiation course for a patient with a brain tumor, as long as they haven't had a seizure, because patients who have seizures, each state has different driving laws, like they can't drive for a certain amount of time after a last seizure. But for patients who are that are cognitively with it, their vision's not impaired, they're not having seizures, they're fully capable of driving themselves to and from the treatments. And in fact, most patients do.
So I have another follow-up question to this. You mentioned the planning process and laying flat on the table, and these treatments are 15 minutes. So the mask itself, can you describe the mask, and what do you do with patients who maybe struggle with claustrophobia or tremors? Right.
So that's a very common thing that we deal with pretty much every day. The mask itself it's like a plastic netting. It's pretty flexible. So yeah, it's like a mesh. So you can see through it just fine. And then for patients who have issues with claustrophobia, one thing that helps is cutting out kind of larger, like the center of the mask, kind of cutting it out. So just like the forehead and the sides and the neck are kind of a bit more immobilized. So that can help. Or just cutting out holes in the eyes and mouth. That can also help a little bit with patient comfort. But sometimes, despite all that, giving some sort of a medication to relax them. You're not putting someone under anesthesia or anything like that, but relax them with different medications. One's called Ativan or Valium, or those kinds of medications is pretty common for patients mostly with claustrophobia. So yeah.
So while we're talking about this planning day, you mentioned that you're determining different levels of radiation. Is everybody getting a different level of radiation, or is there a standard level of radiation? And how do you determine what's toxic versus what's a safe level?
Right. And so for different, like let's say for a patient with a glioblastoma, for instance, and we're not doing some sort of a clinical trial that's investigating the dose or number of treatments of radiation, which I think our main focus is not on those kind of studies, but some places do have those kinds of studies. In that situation, the dose is standardized. So the dose given per day is standardized, and that's kind of determined not as much based on the individual patient if we're giving the same diagnosis across the board, but based more on, okay, for this diagnosis, we know through decades of trial and error, giving higher doses than whatever dose we're giving. In the setting of glioblastoma, it's 60 gray and 30 fractions. We know giving higher doses than that doesn't have a clear benefit in providing more tumor control, for instance, at a cost of more time in my office and a higher risk of side effects and things like that. And conversely, shorter, lower dose courses probably don't work as well, even though they're more convenient. So that part's predetermined often before they come into my office based on the diagnosis that we get at the time of a surgery. With that being said, even with all those things the same, let's say, depending on the size of the tumor or the target and how close it is to some of the really sensitive parts of the brain to radiation, mainly a really central part of the brain called the brainstem, or the part of the brain that controls hearing called the cochlea, or the parts of the brain that control vision, the optic nerves, the chiasm. All these things have very well-established safety limits. And so, part of in the background is making sure that all the surrounding doses as normal structures is well under our safety tolerance, because first do no harm. So that's it's really important. So some stuff standardized, some but things still vary patient to patient. But there's a wide array of the number of treatments, dose, and things like that, depending on what problem we're dealing with, basically.
Yeah. So you're an expert in the field, and this is something that you do every day. Okay. You really have a good understanding of this, of the knowledge that comes with this. And so I think that a lot of glioma patients, when they're Googling, a lot of times they come up with Gamma knife and cyberknife and brachytherapy. Can you talk about those three different types of radiation treatment and how they differ from just your normal standard of care?
Of course. First, I would say expert's a little generous, but I appreciate the high praise.
It's definitely not generous.
Thank you. But so basically, those are all different ways to deliver radiation therapy. The actual fundamental effects, like the therapeutic effects of radiation, are the same no matter whether it's gamma knife, cyber knife, other type of external beam radiation. We use a machine called a true beam, brachytherapy. These are all things you'll read online. They can be confusing. It's kind of shop talk almost, but they're heavily marketed. And so we have all those things available at the Ivy Center at Barrow. So I use gamma knife, cyber knife, true beam, not as much brachytherapy or brachytherapy here, but it's still available with some of our surgeons. CyberKnife and Gamma Knife are two different machines basically to deliver X-ray based radiation therapy or photon based radiation therapy. These terms are the same, but they are used to deliver a type of treatment called stereotactic radiosurgery, or SRS. Not to get too complicated here, all that means is it's a way to deliver a high dose of radiation per day to a very small target over the course of 1 to maybe 5 days or so. And so it's absolutely the right treatment choice for patients with a very small brain tumor where the border between the target and normal brain or other things is very clearly delineated. The target is small and it's far away, or relatively far away. Far for me is a couple millimeters, but far away in our terms from the really important sensitive structures that we talked about. For something so it is absolutely the standard, couple different ways to deliver SRS, which is the standard treatment for patients with brain metastases. So that means that they had a cancer that started elsewhere in the body and eventually spread through the bloodstream into the brain, or smaller primary brain tumors like meningiomas, vestibular schwannomas, pituitary tumors, and a whole host of other things. But for something like a glioma, which is one of the more common primary brain tumors that we see, when we look at, let's say an MRI, when I'm trying to figure out a target, where the surgery happened and maybe any kind of tumor that I can see on an MRI, that actually doesn't show the whole picture. So there's microscopic tumor extensions that kind of go through, that kind of intermix with the normal brain tissue that, even with the best MRI and PET and all these imaging that can image down to like a pixel, like a little sub-millimeter pixel, that there's still a billion cells in like a little pixel or the tip of a ballpoint pen. So there's not a clear border between good and bad cells. And so you want to intentionally treat to a larger area with a little bit of a margin, basically to think a step or two ahead of a tumor in the setting of like a glioma. And so often the targets compared to a brain metastasis or a meningioma are much larger, and they're more irregularly shaped, and we have to give a higher overall total dose. And so if I try to use a machine like a gamma knife or a cyber knife to target that, it's too big of a field for those machines to really safely target, and for me to try and deliver a very high dose to that area in such a short time might actually be dangerous to the patient. So it's not, those machines are marketed as more precise and more cutting edge, but in fact, they've been around for decades. I use them every day. I think about them as just different tools that are the right tools for a different job compared to, like, let's say, caring for a patient for a glioma or a glioblastoma. Hopefully this all kind of makes sense. I'm not trying to get too far into the weeds here. Brachytherapy, on the other hand, so all those different forms, gamma knife, cyber knife, proton therapy, IMRT, VMAT, all these different things that you read about, those are all forms of external radiation. Where basically some device, some machine is delivering radiation, usually using electricity, sometimes using radioactive sources to deliver radiation beams from the outside in from many different angles. Brachytherapy, on the other hand, is we think about it as internal radiation. Brachytherapy just means short therapy. And so what that is it's actually in the setting of brain tumors, for instance, at the time of surgery, the surgeon basically puts these, whether it's some sort of an implant, a mesh. There's a lot of different devices. GammaTile is probably the most commonly used one now, where it has actually radioactive material in it, and that emits X-ray radiation, but over a very short distance, usually over a centimeter or like half an inch or less, basically, and to kind of treat from the inside and try and minimize exposure to kind of the normal nearby stuff, and also deliver some radiation at the time of surgery. So while it's absolutely it's something that we've been using for years as well, we're still trying to figure out how it really fits in the overall grand scheme of things. Certainly in patients with tumors that have recurred or grown back after multiple prior surgeries or prior courses of radiation, that's particularly where we're trying to use brachytherapy to more safely retreat patients who would benefit from more radiation. So that's kind of a little bit of the breakdown of some of the things that you might read about, and some of the things that I think about when I'm trying to figure out what type of radiation to use. Yeah.
With that type of therapy, so traditional radiations, you said like around 6 weeks. How do you regulate when that radiation stops getting delivered, or is it just continuous?
In terms of
the brachytherapy.
The brachytherapy. So for that in particular, it's a very good question. There are a few different types of radioactive materials. We call them radioactive isotopes. Not to totally nerd out for you guys today, but basically we know we have a certain dose that we want to give cumulatively. We have very well established metrics for how much time do these materials give off the radiation, what dose, kind of how long does it take for them to kind of decay and then eventually stop giving off any radiation at all, with terms, something you might read about called a half-life. There's all these different things you read about. So that's all predetermined before a surgery and kind of custom made for the patient. And so usually that's actually given gradually over several weeks, and then eventually the full, like the radioactive material in the brachytherapy implant completely decays, and there's no more radioactive source.
Yeah.
So that's usually still given slowly over several weeks, but often, the radiation is only kind of treating just the immediate area right around where the surgery happened. And so sometimes it's actually really advantageous in some kind of niche situations for something like a glioblastoma, for instance, where we're kind of intentionally, it is a diffuse brain disease. And so sometimes brachytherapy is being studied as kind of a boost to kind of a more external radiation. But often that's one of the limitations or criticisms of using brachytherapy alone as the only source of radiation in patients with glioblastoma. So, yeah.
So with your traditional glioblastoma patient, they go through the standard of care, which is surgery, radiation, chemo.
Yep.
So by the time they're seeing you, most of your patients have had surgery.
Yes.
Is there a timeline that they have to come and see you after surgery? Like, is it, 6 weeks after surgery, they should be seeing you because, radiation gets less effective? Or what is is there a rush after surgery to see a radiation oncologist?
So I would say there's a rush more on my end because I'm a little type A, I like crossing my T's, dotting my I's. Usually, if I'm not seeing them in the hospital a day or two after their surgery, I like seeing them in my clinic a couple weeks, 2-3 weeks afterwards. And I think that is still well early enough where I can meet them, go over the whole process, recommendations. I can get the ball rolling on my end but still allow them time to recover from like a major brain surgery if they've gone through a surgery. Often for patients with glioblastoma or other types of gliomas, ideally we like starting radiation anywhere from about 3 to 6 weeks afterwards. So I like seeing them a week or two before that timeline, just to make sure we're well ahead of schedule. It doesn't, in some situations, if patients need a longer recovery before we start these things, then that's okay. It's kind of a case-by-case basis. But if patients are getting out of surgery well, they're recovering well, that 3 to 6 weeks is a good kind of target. And so I like seeing my office, a week or two after. And there's some thought that evidence is a little conflicting here. There's some thought that if you're starting radiation 6, 7, 8 weeks, really it's 3, 4, 5 months. If we're looking at that the radiation therapy might be a little less effective. We're worried about like early tumor regrowth, for instance, in some situations. But again, sometimes it's this really delicate balance that we have to walk between like making sure they're strong enough after a surgery to kind of do these other things too. So it's okay if it's a little bit longer than that on a case-by-case basis.
So I think that with a lot of other cancers, if you can't get negative margins with the tumor, sometimes you'll end up just going for radiation and chemotherapy, where surgery maybe is not necessary. And so if they can't get negative margins, is that an option for glioblastoma patients because I feel like the surgery is sometimes very daunting for a lot of patients. So is that an option for patients maybe I forego the surgery because, a lot of our patients know that there are microscopic cells left behind. So what's the point of doing this massive surgery if it's not going to get everything?
And so we know that, so there's a couple parts to that question. The most important thing, is, before we even go into surgery, some of the things that, the neurosurgeons here, Dr. Sinai and company kind of look at are how healthy the patient is, any other medical issues that they have. That kind of factors into really kind of this balance between making a decision on a surgery or not, or a more extensive versus less extensive surgery. Probably at least, if not more important, is where's the tumor located? because let's say if they're trying to do a surgery next to a really important part of the brain that might control speech or vision or their ability to walk or things like that, there are some situations where a surgeon might not intentionally not remove that area surgically in order to try and preserve that function, and then use things like radiation therapy and chemotherapy to try and treat the tumor. Again, because first do no harm. However, to take that on the flip side, they've studied this for many years, and most of the medical literature would say, and some of the studies are actually out of Barrow, and they've been published several years ago, that 100%, if you can't get that, if you can at least get most of the tumor out, debulk it, basically, the thresholds we see is about 80% or more. That's kind of the magic number you hear cited, but it's really kind of a spectrum. There is an overall kind of tumor control benefit, and that makes sense. If you're seeing someone with a very large brain tumor, it's causing them a lot of symptoms. If you can at least safely remove most of it, even if you have to leave a little bit behind, that really kind of helps, reset the clock, push things out further. And also, just logically, things like radiation therapy and chemotherapy work better for longer, pound for pound, on a smaller tumor versus a larger one. So there's still a benefit often to even a debulking, or just what we call a maximal safe resection, even if there is some tumor that has to be left behind in order to try and preserve function.
Yeah. So we know the role that surgery takes, in the standard of care, but how does chemo and radiation typically work together?
Right. So many patients, again, if we're talking mostly in the setting of glioblastoma or other gliomas, because we treat hundreds of different kind of types of tumors and scenarios and all that. But so sometimes radiation alone is really standard, and there are some types of brain tumors that we see that don't really benefit from either radiation therapy, or more often they don't benefit from different types of chemotherapy. But that's still an emerging and kind of changing landscape. But in the setting of glioma, really the role of chemotherapy is the main one that's used still today is called TMZ, temozolomide, and its role really is kind of as helps sensitize or kind of amplify the tumor cells to the DNA damage caused by radiation therapy. It acts independently. It acts through mechanisms on tumor cells independently of radiation, but they kind of work together kind of synergistically to kind of amplify and make the radiation stronger and more effective pound for pound. And so we've done studies looking at radiation alone, chemotherapy alone. We know that for most patients, radiation and chemotherapy together offers the best results, but that's very much a case-by-case basis. It also depends on the diagnosis that we're dealing with and the individual patient.
Yeah.
Yep.
So you use the word sensitizes. Can you describe what a radiosensitizer is?
Well, I mean, that's just a broad category of different medications, whether they're conventional chemotherapies that you think of, or other types of targeted therapies that basically, there's many different mechanisms by this, but basically make tumor cells, they basically affect the DNA repair mechanisms of tumor cells, or preferentially tumor cells over normal cells, and try and suppress a tumor cell's ability to repair the DNA damage that's caused by radiation. And by doing that, hopefully increasing the chance that after radiation, the degree of DNA damage is great enough to cause the tumor cell to die off, whether that's at the time of radiation or sometimes several weeks after the radiation's given. So there's a lot of different mechanisms for that, a lot of different medications. TMZ is the one that's been used for a long time, but there are a lot of different, there's been a lot of different basically medications that have been studied over many years. a couple that we're looking at now here. One's called niraparib, and that's what we call a PARP inhibitor. So again, suppresses DNA repair mechanisms. And then another one's called AZD1390, and so that's an ATM inhibitor, which is another kind of really key. It basically blocks one of the tumor cell's key DNA repair, kind of machinery or systems, basically. So yeah. Hopefully that's not all like a second language, and that makes some sense.
No, I think I got it. So if I'm getting it, I think our listeners are
Don't
getting
sell yourself
it.
short, yeah, appreciate it. Yep.
So my next question is, a lot of these patients, and you kind of touched on this earlier, are going to have a recurrence. If they're a glioblastoma patient, the likelihood that they have a recurrence is high. Can you go through radiation treatment multiple times?
You can. I think because that is a conversation that we have from the get-go with my patients. And so, even if with, let's say in the setting of a glio, because there's many patients with different types of brain tumors that we can cure with surgery and radiation. In the setting of glioblastoma, where we can't say that with our current standard of care, which would be surgery, radiation, chemo, that we can cure patients with glioblastoma. Of course, why do we do it? Because we can, at least the best of our ability, try and extend quantity of life, but more importantly, in my mind, quantity of life as well, because tumor progression, tumor growth directly can affect that quality of life as well. And so it can, but those tools do have like a certain mileage. And so, if it's many months or often years after an initial surgery or courses of chemotherapy and radiation, we often can repeat radiation. From a technical side of things, of course we can. In general, it's at least 6 months at a minimum after that original course of radiation, because there's still some ongoing repair of the normal brain and just, that goes on for many weeks or even months after that initial course of radiation. So if it's been at least 6 months or so afterwards, often it's much longer than that. And we, from all the imaging and all the studies we've done, showed that in that individual patient, the radiation the first time around was well tolerated, and it gave a long kind of duration of disease control, basically. That's the time where it logically just makes sense to do it again. Because if it's a short time after several weeks of radiation and we're dealing with a tumor that's already growing back, in my mind, repeating the same thing and expecting different results isn't really in the patient's best interest. But with that being said, if it's been a long time since the prior radiation, we can often safely deliver radiation again. It's usually a shorter course, 2 to 3 weeks at the most, instead of a standard 6-week course. It's often still combined with other medications. It's often after another surgery. And that's really the setting where, through, again, randomized clinical trials that we've done throughout the US, show that, that combination actually has been proven to give some extra benefit. Even if it's modest, it's a relatively quick and well-tolerated tool that we do use from time to time. But most patients do not undergo a second course of radiation, either because they don't need it or because there's other different things or other different type of therapies that we want to explore and might be a better option for the patient.
Yeah, I think the $1 million question that most people want to know probably when they come to see you are, what are the short-term effects or symptoms that they might experience from radiation, and then what are the long-term?
Right. So each day of radiation, like when you come in, you're on the table, deliver the radiation, you leave, most patients don't feel a whole lot different coming in as they do leaving. Of course, if they're claustrophobic or anxious from the mask, that's a different story. And some people feel a little bit more tired at the end of the day. But in general, the short-term effects of radiation over, let's say, a standard 6-week course are gradual and kind of cumulative. So for most patients, that first week or two, if we're talking purely side effects from radiation, they don't notice a whole lot of differences. At the most, maybe some fatigue. As we get to kind of the middle, week 3 or week 4, that fatigue gets a bit more noticeable, okay? It still shouldn't greatly affect their day-to-day activities. And then things like nausea or a dull headache can also come on. Those are a little less common, but they can still happen from the radiation. And then right around that halfway point, around week 3 or week 4, is when most patients do experience some temporary hair loss. Some types of radiation therapy actually don't cause hair loss, but for most patients, they're gonna experience at least some hair loss. Sometimes it's just a small patch. Sometimes it's actually quite a bit of but they don't lose their entire hair like you see with some types of chemotherapy, for instance, but it can still be a lot. So that happens around that week 3 or week 4 of a 6-week course of radiation, and grows back about 1 at the most 2 months after the radiation's done. And then just that last week or 2 of radiation in the week after we finish, things like people are just more tired, a little groggy, sometimes a little bit of what we call brain fog, which is just kind of a, it's kind of a vague term to capture a lot of different kind of symptoms, and maybe headache and nausea. And then just as those things slowly build up over several weeks, they will slowly improve over the next several weeks. Throughout that whole course, I'm seeing my patients every single week. It's kind of scheduled, even if they're doing just fine, to make sure they're getting through that course well. If they're having any issues, we can troubleshoot. That's one of the things that we're pretty good at, and helping manage some of those things if they do occur. And of course, answer any questions that come up throughout that course too. So, and then seeing them after to make sure that those short-term side effects have kind of gone away. So yeah.
Are there any long-term side effects that you've seen are really?
Yeah. So the main thing I would say is that, and not just from the radiation itself, but just from often a kind of spread out several weeks or even months long course, some level of fatigue is normal. So some people can have some degree of permanent fatigue or a little bit of kind of just brain fog, just a little bit slower. And that's not just from radiation. That can just be from a diagnosis of a brain tumor at all, regardless of what we do, or a surgery or chemotherapy. So all those things kind of add up. And radiation's at least partially to blame for that. And that can, most of the time it gets much better and goes mostly away, if not completely, after the radiation. But sometimes you can have that long-term and even permanently. Less commonly, but still probably the most common long-term, and when I mean long-term, several weeks to even well over a year after a course of radiation, to the brain, you can get something called radiation necrosis. And so what that is it's kind of a delayed irritation or inflammation of usually tumor cells and kind of the surrounding adjacent normal brain. And it shows up on an MRI. We're often monitoring how well our things are working with regular MRIs. Sometimes it's just something that we pick up on an MRI, and if a patient isn't feeling any different or anything like that, then we just watch, because for many of those patients, it's just something we pick up on a scan. They're not feeling any different, and it kind of stabilizes, cools off basically just with time. Sometimes that radiation necrosis can be great enough that it causes some new neurologic symptom. Maybe it's a headache. Maybe in some situations it's like a seizure or something like that, or weakness or numbness or speech issues, those kinds of things. Some of the same symptoms that can be caused by a brain tumor itself. And if that's the case, then we'll often try a short course of strong anti-inflammatory medication, so like a steroid. It's a medication called dexamethasone. I prescribe a lot of dexamethasone. And then if that doesn't work over the course of weeks or so, usually a couple weeks or a few weeks, then sometimes we'll add on another medication called Avastin, which is an IV medication. And usually between steroids and less commonly Avastin, that can be kind of reversed or treated. That's the main long-term side effect from the radiation. Less commonly, fortunately, much more rare, if we're treating a tumor really close to, let's say, the optic nerve or the hearing center. Even despite us doing all the safety checks, mapping it out, there's still a very small, maybe 1 in 100 or so risk that the radiation itself can cause like some effects on vision, like some vision loss or hearing loss or those things. Those are exceptionally rare. It's really only in kind of very difficult situations where we're treating a tumor right near those areas. But it can still happen. And those are really the main, and that can happen months afterwards. And so those are really the main things that we can see after radiation to the brain. But the main ones are there's some other less common ones, but those are really the main ones that I talk about with patients. Yeah.
So it sounds like most of these are manageable. Yeah. How do you decipher between, so that radiation necrosis, how do you decipher between like pseudo progression and actual progression, tumor progression?
Right. And so I know you're just to kind of define those things, you're throwing out a lot of medical terms.
Yeah.
So pseudoprogression and radiation necrosis, radiation-induced swelling, radiation-induced inflammation, we're talking about the same thing.
Yeah.
It's all the exact same thing. That is a age-old question that can sometimes it's very obvious. Sometimes just with a standard MRI alone, we can tell. There are certain appearances just on a standard brain MRI of a recurrent or progressive brain tumor that looks different than radiation necrosis. And sometimes it's very obvious to us on that initial MRI. But more often it's a little bit confusing, and sometimes it's a little bit of both. And there can be a little bit of gray area. It can be confusing to patients. It can be just as confusing to experts. And so a couple different things that we use to try and sort this problem out, because it's a really important problem, is there are different, more advanced imaging techniques, so just more non-invasive ways to measure this. There's fancier brain MRI sequences. There's MRI spectroscopy, perfusion imaging. There's other different kind of subcategories of those things. It gets very, very nuanced and specific. And so we can use different special MRIs to help kind of figure and sort those things out. We can use things like PET scans. Okay, that's a little bit more under investigation, but a lot of different major research centers are looking at different types of PET scans to help sort this problem out. But if you don't have those tools available, or it's still up in the air, then sometimes we either have to do a biopsy or do a surgery, basically, to kind of remove that area that's that area of concern and look at it under the microscope, and then we can tell what's what. Sometimes it's all a tumor, sometimes it's all radiation necrosis. More oftentimes it's a little mix of both. And so it just underscores the kind of the gray area that can occur. And so, but those are the different ways that we try and sort those things out.
Yeah.
Yep.
So, in my family's experience, I was the one that did the deep dive on Google. And so I'm glad you brought up radiation necrosis, because when I was going down this rabbit hole, I was like, oh my God, this sounds bad. But now that I have you sitting in front of me, another question that I want to ask that I found on Google when like our family was going through this was that, so we know that radiation damages these cancer cells, their DNA repair mechanism. We know all of that.
Right.
But what about the radiation that affects the healthy tissue? Right. Is that a concern for other cancers, these like cells that were probably mutating? Is that a concern for other cancers cropping up?
So that's particular concern. It's not as much of a concern in adult patients. That is a huge concern in the rare situation. Thankfully, we do not have to use things like radiation therapy or chemotherapy in kids very often. But for some reason, they're more susceptible to these things. Radiation-induced cancers are a real thing. The most common, they're becoming less and less common basically now, just with more focused radiation techniques, and fortunately not having to use radiation as often in younger patients with different brain tumors and other types of cancers. But it still is a effect that is extremely rare, happens in, maybe 1 in 1,000 patients or less, and doesn't happen months afterwards. It happens decades afterwards. Okay. So, but is of a particular concern in either kids or in young adults with kind of indolent benign tumors that they're gonna live many, many years, decades afterwards. So you're right. That is a potential effect. The ways that we minimize that are you need, very fortunately, figuring out ways to, like, other alternative treatments besides radiation therapy, especially for younger patients. Sometimes we still have to do it if necessary, but also using different technologies, whether it's gamma knife, cyber knife, proton therapy, all these state-of-the-art X-ray therapy, to try and minimize, be more precise and more focused, and minimize that normal adjacent tissue to radiation, to try and minimize that risk. But that's still kind of the contributor, we think, for radiation necrosis, kind of in the short term on the months timeline, not the decades timeline. And so most normal brain cells in other parts of the body, their DNA damage repair mechanisms within each individual healthy cell are, in general, they work better. And so those mechanisms are much more effective and much more efficient at repairing radiation-induced DNA damage than tumor cells. And so that's at least the theoretical behind why we think that radiation, or really we observe that radiation works preferentially on tumor cells, whereas in the great majority of patients, they might have temporary side effects, but long-term permanent side effects, although they can absolutely happen, are much less common. So hopefully that answers your question.
Yeah, it definitely does, because I went down this rabbit hole of, weakened blood vessels. Would that lead to clots, things like that?
Right.
So it's good to hear that they're fine-tuning.
Right. It's still not a perfect tool. There's absolutely short and long-term side effects that I spend a great deal of my time counseling patients on. And it's this absolute delicate balance of, for this individual patient, is radiation effective at all? What's the magnitude of benefit that I can kind of basically expect by doing this? I have to weigh that really delicately against the potential short and long-term side effects, some of which can be really serious. And so that's often... anyone can push the radiation button. Right. But really, I think for me at least, the most important part of my job is we're not making a decision for the patient. My job is to just try and kind of translate and kind of relay that balance that I'm trying to strike, and help relay that to a patient and their family to figure out, is this the right decision for them? But it is a very delicate balance that we have to walk every day.
Yeah. So, I feel like this field has come a long way in the past, even 10, 20 years for sure.
Oh, yeah.
So when you're looking through it all, what do you feel is the most exciting change in the field?
The biggest thing overall, at least in radiation oncology in particular, is really just the advancements in technology, but really just the advancements in being able to deliver radiation much more precisely. Some of that's just through getting more sophisticated with the type of machines that actually generate and deliver radiation therapy. But that goes in parallel with more advanced imaging techniques, so we can be a little bit more precise. We can be a little bit more certain about what we're trying to target and better differentiate the good stuff from the bad stuff. So and so there's several different advancements along that line that have made radiation much safer while still maintaining its effectiveness. So that's kind of the nerdy physics, technology stuff in the background that I really enjoy. And in my opinion, it's been the biggest advancement in radiation therapy itself. With that being said, really, radiation is still just one tool overall in kind of caring for patients with brain tumors or other different diagnoses. And so, of course, radiation still does and will play a critical role in that for years to come. Of course, not forever, right? But for many years to come. But I think the more exciting thing in the oncology kind of field in general is understanding the kind of that cancer is not just one kind of disease. It is hundreds, if not thousands of different diseases, and then trying to figure out the individual causes for each of those, and then developing whether it's different therapies to really kind of hone in and be a little bit more targeted and patient-specific, a little bit more personalized medicine. So we have a long ways to go even in that realm, but that's kind of that general field is the most exciting to me, and I think will overall push the move the needle the most. And that's really some of the things that we're focusing on here at Ivy, but also many big major academic centers throughout the country are too. So yeah.
Well, I feel like this was an extremely comprehensive overview, and I really appreciate you joining us today. I think that you covered every topic that I went through when we were going through this, so I just appreciate you joining us today and for sharing your knowledge with all the patients and caregivers who are going through this. Yeah. But one thing I do want to end the episode with, we always end each episode with this, is that we hear the expression, the 1 day at a time, 1 second at a time, 1 minute at a time, all the time from patients and caregivers. So I would like to do a quick fire with you of your one thing or idea or feeling about that holds some significance to you. Are you ready?
Yeah.
Okay, what's one piece of advice you would give to your younger self?
I would say, if we're going to get real serious, stop worrying about things that you can't control and letting go of things that you can't control.
Oh, that's a good one. I need that one. What's one thing people would be surprised to learn about you?
I don't Google this. I mean, I know you're pretty good at Google, it sounds like. I may or may not have been in a really bad punk band, like a punk garage band, back in Gainesville, Florida, back in middle school and high school. So don't look up MySpace. I don't even know if MySpace is still a website, but anyway, yeah.
To all the listeners, we should absolutely look that up. Yeah. What's one thing you do to de-stress?
I would say for me, I'm a washed up cross-country runner from college, so I still like to run. That's the best way to de-stress when it's 115 degrees out, treadmill, and then I like going to stand-up shows, so like seeing stand-up comedy, either watching it on YouTube or going to stand-up live downtown. So,
what's one habit you'd like to break?
My crippling caffeine addiction. Yeah, it's truly debilitating financially, and just
I'm never going to break that one.
Yeah, same.
What's one book you'd recommend everyone reads?
The Emperor of All Maladies by Siddhartha Mukherjee. So I won a Pulitzer Prize for this. Just to stay on topic, it's a kind of an overview of really cancer as a whole, really even evidence throughout ancient civilization that this was something that was there even then, but more importantly now kind of outlining and telling a story really over the past 100 years or so of all the different discoveries about our understanding of different types of cancers and all these different breakthroughs and really all the stories behind that. And so it's really inspiring. And so I love that book. Yeah.
What's one thing you're most proud of?
Well, I'm not going to brag too much, but I have kept 4 houseplants alive for over a year now. So that's a big deal. Yep.
If you weren't a radiation oncologist, what's one profession you'd want to try?
Marine biology. So ever since, super weird, but ever since I was a kid, I have very fond memories of going fishing with my dad. I grew up in North Florida and keeping aquarium fish and all that. So I was always super fascinated by it. I did my AP Bio kind of capstone paper on the chambered nautilus, basically. So it's just a weird thing, but that would be kind of if I didn't do medicine, I'd go into marine biology research. So.
Okay, last one. What's one thing you'd be remembered for?
One thing I'd be remembered for? Well.
Or one thing you'd like to be remembered for?
So, just to tell a little bit of my story, I got into this because my dad also got diagnosed with a brain tumor when I was a kid, and so what I didn't totally understand everything that was going on. He was 7 when I got diagnosed. He passed when I was a junior in college, and so it was a long journey. I don't remember every little detail of of what went on. But the one thing I do remember is the care that he got and the doctors that were caring for him to make sure that he was well cared for. And so I remember that's why I got into medicine in the first place. And so my goal is to be remembered by someone's kid just like I remembered them. And so that's what I want to be remembered, even if it's just for one person. So I just want to be that person for a patient and their family and try and make this whole process a little bit less scary. And so that's it.
Well, thank you for coming on here and for sharing. We really appreciate it.
Yeah, of course. Well, I appreciate you having me.
We hope this episode has informed and inspired you. Subscribe to Brain Tumor Talk so you don't miss another episode, and please consider leaving us a review to help others in the brain tumor community find us.